She then went back to hardcore academia at Stanford and has had a gigantic impact in movement disorders and deep brain stimulation. And was one of the very first people to have access to the Medtronic Activa PC plus S DBS device. And I think we're going to hear a lot about that today. So.
So seeing is it on? Thank you very much, Cameron. I'm really honored to be here, and I thought the one detail I'd fill in for you to get a little credibility is I actually have a master's degree in bioengineering from Penn, so I can speak the language a bit, although my lab is full of engineers who do the real work. The other thing I'm going to talk about is actually how I got interested in this whole field, which I've had the joy of talking to several people about today. And really, what I am trying to do, as I know a lot of the people here are trying to do, is understand how the brain controls movement. And we're all doing this in different ways. And as you can see from these pictures are of people who are highly trained in some motor act. And I got interested because I come from a world of dance. That's a very difficult thing to do, engineering-wise. Can you imagine, get your whole center of gravity over that base of support? And if you ever want to take this up, I'll give you one secret. Think of going forward, not up. You actually get there better. But when I was in ballet in England and Scotland, you have to go through a series of exams to get to your professional level. And when you get to the major exams, you get to do them in big, scary cities like Edinburgh. And as a teenager, I was over there with one other student, and we were in the center in our point shoes, and this very awful, stern ballet mistress, and they always were. The examiners were probably some of the most angry-looking people I've ever seen in my life. And they don't speak to you, and they just go like this. And they literally do that for about 20 seconds. The pianist starts, and you do it. It comes out on your feet on point. And I remember going home in the train that night, and I thought, wow, I wonder how my brain did that, because I didn't really think about it. And if you think about it, you never want to think about this when you're doing a highly skilled movement. And this applies to musicians. And so I thought I'd give you a little example of something like that. And on YouTube, the best thing I could find is a video of the Royal Ballet class that was put out for everybody to see. And they've got a ballet teacher telling them what to do. And she's much nicer than the examiners I had. But let's see if this will play. And what you'll hear is you'll hear her just telling them what to do, and then they do it. Do we have audio?
Sure.
Oh dear, we don't have audio.
Actually, sometimes you have to plug.
It's in. Okay, so first piece that went bust. So what she just did is she gave them a verbal command, and they just literally do it. And of course, this is exactly what you're trained to do as a dancer, because what you've done is you've learned a bunch of repertoires of single little pieces that go together and make up a complex movement. And it's okay, because we'll go on to videos. I don't need the sample. And so I ended up, or I am now, studying a disease where people have actually lost exactly that function that I was so interested that we had, which is to recruit automatic or well-learned movement. And I'm not talking about enchaînements in the center of a ballet studio. I'm talking about walking. And when you get up and walk and go and get a cup of tea, you're not really thinking about how you have to walk. People with Parkinson's disease have to recreate this from first principles. So they need coincident, congruent sensory feedback. And that's a real mainstay of what we do. So here's the challenge. Parkinson's disease affects all our networks: sensory motor, limbic, associative brain circuitry, and the autonomic nervous system. And how do we access such circuitry in the human subject? And luckily, you'll see this lady now is about 6 months post-DBS. It looks like she got all that connection back. She can grab those automatic programs. She's just going to charge off down the corridor. She's not on any medication. And look how fluid her walking is. And it's like we turned a switch. And so sensory motor circuits in the basal ganglia have characteristic physiological signatures and topography that guide the placement of chronic stimulating electrodes, which we call deep brain stimulation in the clinical field, which treat Parkinson's disease and other movement disorders. And this opportunity has now allowed us to access brain circuitry in human subjects. So the point of this talk, as I'm going to come to, is really how can we use that knowledge of brain circuitry, or how do we use the behavior to turn around and then drive more sophisticated devices that are then designed to treat the disease based on the abnormal signals or the abnormal behavior. And I'm going to kind of get to this. But as a person who had no idea how to do this, because the best thing you had to use to measure movement in Parkinson's disease were clinical rating scales, I kind of had a thought of what we had to do. So big problem, first of all, is unlike monkeys, and we've talked to lots of monkey people, and I was a monkey person in Lisberger's lab, and it took me 6 months to train a monkey to do an eye movement. Humans can perform complex movement without much training, and they don't pull off the leaves with their fingers and things like that. But how do you measure these complex movements quantitatively in the human, which is actually why I landed up in Lisberger's lab, because I wanted to understand the basis of motor learning in the 3 neuronal arc of the VOR. And then how do you do this in neurological diseases that cause movement disorders? So I set about developing what I call my widget factory, and we developed quantitative methods to measure fine motor control, limb motor control, and now axial motor control using initially a MIDI interface musical keyboard, and then using the first generation of wearable sensors, which this is a gyro, so this is a solid-state gyroscope that measures angular velocity. And as you'll see, I'll show you, we measured some nice freezing of gait metrics using a dual force plate and a stepping in place task. And I'm literally just going to touch down on many years of work for this. So just to show you, and you can see the papers here, is that I wanted to use a complex enough movement that it would really somewhat challenge the brain. And in the UPDRS, the Parkinson's rating scale, this tapping task has been shown to be the single task that is the most highly correlated with overall motor disability. So we used an alternating tapping task. And so this is one finger, and that's the other finger basically doing a trill. And you can see that the velocity of movement, or the force exerted on this musical keyboard, is basically the height of the strike, and the duration of strike is the width, and the interval is obviously the ISI, or the interstrike interval. And from that, we validated this to the UPDRS and found, in fact, some very interesting things out of this line of motor control, which is in Parkinson's disease, it's the temporal regularity of movement that's the most highly correlated with their overall motor disability. But here you can see, here's a normal control subject doing a very nice fast trill. Here's a very early stage Parkinson's disease person. This is the lesser affected side, and this is the more affected side. And it's just a visual. You can see how sensitive this is to pick up this abnormal movement in the patient. And so this was validated, as I said, in a very sensitive measure of overall motor disability. We have subsequently gone on to design and build an engineered keyboard that's a lot more sensitive. And Anka Velisar in my lab has done some very nice calibration showing that as you press the key down, you have a linear zone and a nonlinear zone. Now we can actually measure the amplitudes, both of the down strike and the release strike, along with actually measuring tremor within this. And one of the research associates in my lab who's just started med school, Megan Traeger, worked with this for quite a long time, published a nice paper basically stemming off other papers that looked at just single-digit tapping and showed that, in fact, if you use a Uni Manual alternating finger tapping task, you're much more likely to pull out the motor control abnormalities in Parkinson's disease than if you use a single finger alternating hand task. And it's not real rocket science, because your lesser affected hemisphere drives the more affected hemispheres in this task. So in fact, when you use the Uni Manual task, you bring out the signs of Parkinson's disease much more accurately. And this actually also stemmed from a question about whether you see freezing in fine motor control, and we do. And I'll show you this. The next thing is the gyro, the angular velocity sensor. Now everybody's using wearable sensors. And again, quite early on, we showed that this was a sensitive measure of bradykinesia, control, Parkinson's lesser affected side, and more affected side. The y-axis is angular velocity over time, and you can see again this temporal irregularity, and you can see the frequency and the velocity are very different. And I'll touch back on how we've used these as we move forward. And then we use a stepping in place task on a dual force plate, where we have shown that, in fact, you can use this stepping in place task to measure freezing of gait or freezing episodes. And we validated this, and the international standard, again, was only a questionnaire. So we validated it with the international freezing of gait questionnaire, and here are just examples of a person who never froze, and you can see this beautiful regular stepping in place. And how we measured it was we basically normalized the force to the patient's body weight. So 100% is when your weight is purely on one foot, and 0 will be the corresponding foot will be off the force plate. So it's a very nice, again, visual to see that when you don't get the feet off the force plate, you're frozen. And we developed a computerized algorithm to detect these freezes. And Julian Antal, a postdoc in my lab, who's now at University of Ottawa, did a very nice job with this, validating it and showing that as you get more severe in terms of how often you freeze, you can see that this comes out in the force plates and the stepping in place task. And just to note to you, it's very interesting to me that not all freezes are the same. There are some where basically your weight is shifted, maybe more on one leg, but you're literally not putting any signal through the feet, whereas you can see here the feet are actually not coming off the force plate, but you can still see this very nice alternating signal. So for people who are interested in neural signals, my question is, are the neural signals different here from here? And this is just to show you, this is the force plate showing freezing behavior, and we've just color-coded it the way we do the QDG, the keyboard, and you can see this is somebody doing that repetitive alternating finger tapping, and we can also bring out freezing episodes with this task, which they could not with the single-digit tapping with 2 hands. So here we've now developed some measures of human movement, but now here's the next question. The brain is protected by a thick skull. And how do you access brain circuitry to measure neural activity in human subjects, especially in deep regions of the brain, such as the basal ganglia? Next problem is, how do you do this while humans are moving? And how do you then measure both movement and neural activity in real time? So of course, the next reason that the brain has given us why we can do this is that the brain segregates our networks somewhat anatomically, and this of course has allowed us to do procedures like deep brain stimulation for movement disorders and not, at least overall, affect limbic or associative circuitry. And this goes right through the cortex and the basal ganglia, and we have been doing a lot of our implants, and our Activa PC+S recording is from the subthalamic nucleus. So just to not go through the circuitry that I know everybody hates, but just to kind of alert you to a couple of pathways I'll be talking about, is that the subthalamic nucleus receives this direct monosynaptic pathway from the cortex, which is called the hyperdirect pathway, or HDP. And also, as you know, the STN feeds back with an excitatory feedback to GPI and GPE. And there is, as many of you work with, the potential for multiple oscillatory loops in this circuitry, which I think we can harness and use to our advantage to understand brain mechanisms of motor control when we do some of the experiments we do. And again, as people who know this in depth know, I'm just kind of touching on things here. So as we all know, deep brain stimulation for movement disorders could be regarded as the first generation of brain pacemaker. And to do this, you use frame-based or frameless stereotaxy to accurately target these deep brain structures. And here's my colleague and partner, Jamie Henderson, who many of you know well, who pioneered the frameless technique. And we assist him in the operating room using microelectrode recording. And here I have one of the the gyros on the dorsum of the foot, and we instrument both the hand and the foot. And I use this in order to determine that we are getting improvement from placement of the DBS lead, and I also use it to do my recording. So here are the opportunities. During the operation to place the DBS lead, we can now access this brain circuitry, at least in our case in Parkinson's disease and also dystonia and tremor. We can record from such circuitry while consenting human subjects are awake and at rest, because that's how they are in the procedure normally when we're doing microelectrode recording. And we can do it while they perform simple movements, and I'll show you some of the experiments we've done in the operating room. However, as everyone knows, this is a very time-limited experiment. I mean, these are patients who are fairly tired. They've been in the operating room. We've done MER. That means we've had a small lesion effect. It's a very expensive lab to have, is the operating room. And they can't get up and move freely, and so this is a very somewhat strange experimental setting, but it's what many of us have done for many years. And the other problem is that we've got to access these very deep regions of the brain. And we've got to get in there, and we've got to record from neurons. And we do this, as people here do, by using these microelectrodes and doing extracellular recording. And from that, we can get very nice single units. And we have a Faraday cage. We have a shielded OR, and we actually have beautiful signal-to-noise ratio in the OR, which has made our research possible. And we can use this, as I said, to actually do the mapping. And so here's my angular velocity sensor. And although you can see the foot, this is actually from a wrist extension movement. And you can see the movement. And you can see this nice neuron in the STN responding beautifully. And so that tells me when I'm listening to this that I'm actually in the sensory motor region. And I literally, to map, I go up and down the body, as does Dr. Kilbane here, moving all the joints and making sure that we're in the middle of the sensory motor region before we place the lead. We can also record the local field potential, which is basically the local summation of electric network activity. And Cameron and I have discussed about how this is under great debate as to what the local field potential actually represents. But this is what I'm going to be talking about from now on, is actually using the local field potential to understand more about brain signals and movement. And so we've completed a study. I decided that I approached the LFP with a lot of skepticism in this beta band when Peter Brown and colleagues were really publishing the first papers about beta rhythm. And so we set about doing a prospective study where everybody who consented in the OR, we would do 60 seconds of rest recording once we'd placed the lead. So we didn't use it to place the lead. We placed the lead and then did these recordings. They were instrumented with wearable sensors, EMG, and synchronous video so that we could make sure that they were truly rest recordings. From that, we culled out of about 180 STNs, we got down to 130 once we took out artifact and movement. And we're recording these channel pairs from the DBS lead. So this is a sagittal section of the subthalamic nucleus, and here's the 3389, the small DBS lead with 4 electrodes on it, conveniently named 0, 1, 2, and 3. And so what we're doing is we're recording from each channel pair. And so you can see that here's the recording from channel pair 0 to 1, 1 to 2, and 2 to 3. And this is what's called a time-frequency spectrogram. And so for those of you who are not used to looking at this, the hotter colors in red symbolize greater power. And so when we do a power spectral density diagram, we can see across the channel pairs that we got the greatest amount of power, and this is resting state, over this lead 1 to 2, which was right here. There was still power in the dorsal lead, and there was very little power in the more ventral channel pair. And so we have, using a peak detection algorithm, we actually have seen a peak in this beta region in 129 out of 130 of those STNs in the 8 to 30 hertz range. And that also has been an area of discussion as to actually how often does this really occur in PD STN. And we've gone on to do a study of this, which hopefully will be accepted quite soon, which is we then looked at all of these patients and we said, within a patient, is there a difference in the power in one STN versus the other based on which side of the disease is more severe? So for those of you who aren't in clinical neurology, Parkinson's disease always starts on one side of the body, and that side of the body tends to remain the more affected side. And what we've noticed in looking at the data is in patients who were more affected on one side, it seemed like the power in the contralateral STN was higher. And sure enough, when we did this over the group, we found that there was a significantly higher power in this beta band in the more affected STN compared to the lesser affected STN. I want to make sure that people realize this was not a correlation of power to these UPDRS scores across the whole group. This was within patients statistic. And I can tell you that every reviewer seemed to mix that up. And because so far nobody's really shown that there's actually a correlation between the power in the beta band and a UPDRS score. There's correlation with changes in function, but not with the actual score. So this to us was actually very interesting, suggesting that this is a function of stage of disease, and I'm going to show you some data from our PC+S patients that I think is supporting that in my mind. So just going back to the early literature, it was suggested that this beta band was a biomarker of Parkinson's, largely from groups in Europe and groups in Canada who can externalize these leads after they place the lead, and then they have a period of a few days before they implant the generator. And during that time, they can do some recordings from the STN or GPI. We don't do that in our center and most of the centers in the United States. The neurosurgeons are a bit concerned about infection, so all of our work had to be done in the operating room. When you did that and you actually gave people some medication and kept recording this signal, you saw that this beta band went away. And in some cases, it actually was, there was a gamma band associated with it, which led them to suggest that the beta band was akinetic and the gamma band was prokinetic. My immediate skeptical statement was, well, if that's true, then the other therapy that really improves Parkinson's disease, i.e. DBS, should also attenuate this beta band. So we had done a little bit of work recording after we had applied DBS initially, and then once we could all record during neurostimulation using an analog filter, we applied randomized presentations of different voltages of DBS, and we recorded the beta during that period of time. So this is the time frequency spectrogram, resting state recording in the operating room. This is when we gradually turn up the voltage to make sure that there are no adverse effects, and you can see that there's this dramatic loss in signal. And then we apply periods of different randomized presentations of voltage, and you can see across the group there was nice dose-dependent or voltage-dependent attenuation of resting state beta band power. And when you get out to these voltages, this is usually the clinical voltages people are using to treat Parkinson's disease. So from our operative work, we could learn several things about this signal. And then we went on to think about the network. So can we access other parts of the network? And what about this rhythm? Is this something that's distributed in the sensory motor region or not? And most of you are probably familiar with Viviana Gradinaro's 2009 science paper. And we were working with Carl and Viviana. And when they really showed, at least in a behavioral model, that the hyperdirect pathway seemed to be a very interesting pathway to be modulated by DBS in order to get the effects that we would see in the human. Jamie Henderson and our neuroradiology group did some tractography and identified, as best they could, the hyperdirect pathway from the cortex to the STN. And then what we did was, in the operating room, he and our physicist, Bruce Hill, introduced a cortical strip electrode under the burr hole, and with image guidance tried to get it right over this DTI site here. Then we went ahead and we did our normal procedure and placed the DBS lead in one of the STNs. And then on the side ipsilateral to the cortex, we came in and we initially did LFP recordings at a 1 millimeter basis as we slid the cannula down that drives over the microelectrode. And then what I was also very interested in is whether there was coherence between STNs, because, and that's, I can't talk about this in our papers that Camille de Solage did, we actually did show that there was coherence between both STNs so that they were functionally connected. And we found in the functionally connected site in the STN, there was also functional connectivity with the ipsilateral cortex. So once we found that, which you can see on this next slide, this is the coherence between ipsilateral STN, and now we're recording over the cortical strip electrode pairs. So this is not an STN, this is now up in the cortex. And then we applied the same randomized episodes of randomized voltages of STN DBS, and now we're recording the cortex. And in the regions that were functionally connected, we could see that there was beta in the cortex, and we also could see that there was attenuation during DBS, and not so much when we were in non-functionally connected sites. Anyone who's seen that paper will know that the number of subjects we got through this experiment was extremely small, and we saw this in a few of them, and in one of them we didn't see this, and we were like, well, maybe this is not real, until Jamie came back to us, and after he'd done the reconstructions, he said, oh, guys, one of these leads actually slipped. It wasn't over the DTI site, and in fact, that was the person where we actually didn't see anything. So although that is a very anecdotal result, it was a very interesting result that in fact in the functionally connected sites between STN and the cortex, STN DBS does in fact attenuate that cortical beta as well. So that suggested to me that this beta rhythm is a property of the distributed sensory and motor network bilaterally. So in the operating room, we can do a few tasks because people are awake and they can move. And so this is synchronized now, angular velocity data and local field potential recording as somebody's at rest and then does this movement, flexion extension, and then we start DBS, and you can see we wipe out this band, the patient gets a lot better, we turn it off, the patient begins to get worse again, but takes a while. And what you can see here, which is really interesting, is that when they are at rest, you see this nice broad band of this beta band. When they start to move, there is a period when this is attenuated, but remember, that's not the same 150 milliseconds that you see in the cortex prior to a single movement. This is anywhere from 2 to 6 seconds while they're moving. And then this interesting band comes back that we now call the movement band that tends to be more focused. And you'll see that a little bit more. That was our first inkling that there was something different going on when patients moved compared to when they were at rest. Most studies still just focus on the resting state beta. So that's all fine and good. And until recently, it was only possible to access this deep brain circuitry when the leads were externalized, and the subjects basically are tethered. Even when they're out of the operating room, everything was tethered to the equipment, and we, as we said, could only do this in the operating room. So how do you access brain circuitry to measure both neural and kinematic activity while humans are freely moving? And so my two desires right from when I started, which was brain and behavior, were always separated until this wonderful thing happened where we were actually asked to send in a proposal to Medtronic to use a new investigational device that had sensing software literally put onto the FDA-approved Activa PC. And it was firewall protected from the sensing, from the stimulating software, but we still had to go through the FDA and get an IDE. So if we can access brain circuitry in freely moving subjects using a sensing neurostimulation, we've got two things we can do. We can now investigate the neural basis for neuropsychiatric diseases in general, and for me it's in movement, motor control, and we can use the brain or kinematic signals to develop the first closed-loop brain pacemakers. So this was our first subject who just came back for his almost 3-year follow-up, and he comes every 3 months, and he has consented. He wants everybody to see his photograph everywhere. He's so excited. And so we implanted him on October the 30th, almost 3 years ago, and this part was called the Brain Radio Project, and our Brain Radio Project was to investigate the neural signatures for tremor, bradykinesia, and now freezing behavior in Parkinson's disease. So basically, we have implanted 21 subjects. The most recent subject we had to explant due to infection. And you can see from here their age, their preoperative. This is the clinical rating scale. So for the neurologists in the audience, you can see that they had a nice improvement from their medication. And at the 6 months postoperative, they're doing extremely well clinically with DBS. And I have to say a shout out here to Dr. Kilbane, who is extremely involved in this project and would come running up to me and like, I have a great candidate, and she did. So Camilla has given us many of our really wonderful patients in the Brain Radio Project, some of whom were asking about you. I told them I was going to see you. So great shout out. So now we can do continuous recording here. Now we couldn't do this in the operating room, but this is a continuous over 8 minutes of recording. And again, being an immense skeptic of this, I thought, okay, it's fine. We've got resting state in the operating room. Great. If you look at most of the papers, they only do one resting state in every time they present any kind of research. And I published a paper where I looked at 5 different resting states, and I perturbed the system in between it to see if there was anything different, and there wasn't. And this time I was like, okay, what about if you're sitting at rest versus lying at rest versus standing at rest? Because if we're going to do this in real walkie-talkie people, we're going to need to be able to access circuitry when they're doing different resting postures and different movements. So I'm not going to go, you can see in the paper the answer, but you can see from the spectrogram that here's this person sitting. Then we have a nice yoga mat we had in our lab they got to lie on. So this is the transition of getting up, transitioning to lie down, and then transitioning to stand up. So the two things you notice out of here is that when they're sitting, lying, and standing, it looks similar, and in fact it was. And when they transition, it looks different. And you can see this because these are our wearable sensors on their body to tell us that they were actually still and then when they were moving. So we were comfortable in that the resting state does appear to be a resting state rhythm. And this is the first time that we were ever able to get synchronized video and brain readout of somebody freely moving in our lab. And here you can see a gentleman standing. And what you're going to see is he's going to take off. He has a little start hesitation. And you can see his rhythm changes immediately. And then he carries on walking around the lab. And he is not instrumented. And right now we have a fair number of subjects who are instrumented with forward of walking and another very interesting turning and barrier course that one of my labs developed. So we now have kinematics for this as well. But this was highly exciting when when Anka Velasar first put this video together. And what you can see from here is here's his resting state. And in fact, when he's walking around, his PSD does in fact change. We've also used this with that stepping in place task that I talked to you about. And for those of you who are engineers, you'll know that we have a very highly sophisticated way of synchronizing that data as we have a hammer that we bash on the force plates. And it works. And patients wonder why there's a hammer sitting there when they get up on the force plate. But so what we do is we have them standing, and here's their neural correlate of their standing signal. And then we ask them to start doing this stepping in place task. And here's this person stepping nicely, and then they begin to freeze. And now we have the neural readout. And I'm not going to give you the answer to this because I don't know the answer to this yet. But here you can see their standing or resting state in the blue. And this is when they are actually stepping, is the green, without freezing. And you can see when they're freezing, there is actually a slight difference in the signal in this subject. And that is a very difficult project, but we have a lot of data on it now. Something just to talk about, when you're doing this long study, now you can access brain circuitry over time. And we have almost 3 years. So one of the questions I thought was, hey, what's happening to this over time with disease progression? Now, obviously, we also have people who are being stimulated chronically, and it's really sort of unnatural to stimulate the brain at high frequencies continuously 24/7. So what's happening to this rhythm? I mean, there's got to be some kind of LTP or LTD going on in the brain. So what we did is every 3 months for the first year and every 6 months afterwards, we are doing what we call our washout experiment. And Megan Traeger has just published this. And what we do is we withdraw stimulation, and we test 0, 15, 30, 45, 60 minutes. We've shown that there's no difference between when you turn it off and start recording, it's about 15 seconds, compared to an hour later. So that tells any of you who are interested in this that you can turn off stimulation, you'll have a fairly stable rhythm almost immediately. But then after 6 months and after a year, the red and the blue, you can see a very interesting phenomenon happening, which is their resting state band is being attenuated. This is off stimulation after chronic DBS, and that was statistically significant. There were 2 subjects in whom we only stimulated on one side. They wanted both sides implanted, but they only wanted one side turned on. I made sure somebody else talked about that to them because I was so excited about that. I was really, but it was their choice. And so what we got to do was we got to measure the beta band basically in its natural PD state. And what happened is these are the stimulated STNs. The black here is initial programming, so that's before stimulation was starting. And you can see at least in the beta band, this is attenuating, although there's a band here increasing in this patient. And here in this patient, you can see that the band is attenuating. And unfortunately for this patient, what we saw is initially, this band looked like it was going down, but literally at 18 and 24 months, we started seeing this growing. And in fact, in each time, I would ask him whether he wanted the other side turned on without looking at the resting state. And he asked us to turn him on basically at the 24-month period. So we will now see if that's going to start decreasing. What you don't see here is this gentleman's 30-month, which we just did a couple of weeks ago. And it actually is poking up here. And he asked us to turn him on. So this, getting back to the more and lesser affected stage of disease, this is almost like a confirmation to me that this is somehow reflecting progression of disease, and somehow we're attenuating it with chronic high-frequency deep brain stimulation. So can we use the neuromodulation as an investigative tool? And Cameron and I have talked about this in the past. So we've talked about recording from human brain circuitry. Now can we use neurostimulation actually to probe that circuitry as an intervention? So one of the things we know in Parkinson's disease that's always been a question is what frequency should you use? And we use high frequencies based on a lot of work that Alim Benabid and his group did many, many years ago, showing that basically anything between 100 and 200 hertz was efficacious and everything below that was not. We now know that, in fact, there may be a role for a lower frequency like 60 hertz in walking and freezing a gait, but we all know as clinicians that people who have tremor need a higher frequency. So the question is, why is that? What's happening in the circuits? What's happening with the rhythms? And what about, as many people here are involved in, what about these other disorders who are just using the movement disorders frequencies kind of without really any evidence as to what frequency they should be using? So using different stimulation parameters, we can record these rhythms and kind of probe the circuits and see what's happening in the brain, which may shed some insight into the functional role of different neural rhythms and circuits in the brain. And in my opinion, this was the electrophysiological equivalent of the knock-in, knock-out methods. If you can knock this rhythm out, what happens to the behavior? If you can knock it in, what happens to the behavior? And I honestly thought I was a home run when I did an experiment in the operating room looking at the resting state during 60 hertz DBS and during 130 hertz DBS. 60 hertz was no magic about it. By recording around the stimulating electrode, you basically can only resolve frequencies if you have a stimulation frequency 2 times the frequency of the rhythm of the band you want to record from. So 60 was as low as we could get at that point. And lo and behold, what was very interesting was, here's the baseline resting state, here's 130 hertz at 3 volts, and what we used, why we used 1.35 volts is we used basically the same energy delivery that we would deliver with 60 hertz at 2 volts to make sure that it was actually a frequency effect and not just an energy or power effect. But you can see, and obviously we're showing you our most dramatic case, this person's beta band was amplified. If you normalize it to the baseline state, you can see that high frequency attenuated this and 60 hertz amplified it. And I thought, home run. Here we go with our Activa PC plus S patients. Now we're going to do walking around experiments. We're going to see whether their band is amplified, but they're better or they're worse. So we started with bradykinesia. And this work was pioneered and done by Zach Blumenfeld in my lab, who's an amazing researcher and who's just started med school. And has had a kind of a jolt in the kind of learning he's doing now compared to what he was doing in my lab. So what we said, we approached the first thing, which was bradykinesia. Flexion extension task, you probably are all familiar with this right now. Here's the angular velocity sensor, and here's resting state. This is a person who's not on stim, so they begin quite nicely, but you can see how they get so much slower, both in the velocity and frequency domain. Turn on 60 hertz. For this person, it looks like their resting state was attenuated. And as soon as they start moving, they're much better. And you turn on high frequency, they look like, for this person, they actually have higher velocity, but they actually peter out faster than they did at 60 hertz. And lo and behold, in actual fact, both 60 hertz and 140 hertz improved bradykinesia, which was a little surprise to me. I was not expecting that. And when we did a 20 hertz kinematic experiment, because we couldn't resolve the LFPs at that frequency, we actually saw that 20 hertz did not make them worse. So the whole frequency of amplifying beta and making them worse didn't seem to be, although we don't know for sure that 20 hertz is amplifying SCN beta. But so 60 hertz and 140 hertz improved the velocity and the frequency of movement from the no DBS setting, and only 60 actually improved the regularity of movement. And right from the beginning, I told you regularity of movement in PD is one of the most highly correlated with the overall disease. And I actually noticed that in the OR, even though I was blinded to what stimulation frequency it was. At 60, I just saw these people going like this, and they just didn't seem to get irregular. And when you see them with 140, they kind of peter out a little bit. So what about the neural signals? Oh, before I do that, I'm just going to show you the nifty video that Anka made. Excuse me. And this is now in movement disorders. So you can see here he is sitting at rest, and you'll watch his movement. It's always easier to see his movement, but you'll see he starts doing his flexion extension. You can see quite quickly what we call progressive bradykinesia. He gets much slower, and he peters out. And now you can see with 60 hertz DBS, he's going to do the same movement, sitting nice and still, instrumented, all synchronized, kinematic and neural and video. And you can see he's much better on 60 hertz. And again, he just seems to keep going. And you can see from the traces he's actually getting a little slower. You don't really notice it in his movement. And now we're going to do high frequency. And for those of you who are wondering why we use 140 and not 130, it's because of the subharmonics with Activa PC plus S that are actually fewer in the beta region with 140 than 130. And again, you can see it's kind of petering out and getting a little more irregular with that high frequency still. So I'm sure you're all sitting on the edge of your seats wondering what happened with LFPs. Like, no, this is really boring. Well, look what happened. So here's his resting state, the green. Here's his movement, so it's attenuated resting state. Now we're going to look at movement compared to 60 hertz, and look what happens. This low frequency band is amplified, and the high beta band is attenuated, and yet with 140 hertz, the whole of the band is attenuated. None of this actually correlated with any of the kinematics once we did some very conservative statistics. But so what was really interesting is what is going on. If any of you have read the Oswald paper with Peter Brown's group, you may have seen that using MEG and also LFP recordings with STN, local field potential recordings, they are suggesting that in fact the hyperdirect pathway is mediated by high beta frequencies, and the lower beta frequencies represent these sort of STN striatal circuits. And so we have extrapolated to suggest that now using this is a tool to investigate circuitry, we can actually show, and if Cameron's recent review paper, it might make sense, that if you're antidromically stimulating this hyperdirect pathway, you may be attenuating a cortical beta that's being reflected in this in the STN. But in actual fact, with that low frequency, you're somehow amplifying some loops in this circuitry. I'm just going to take one little step of generalization, or maybe this may not be right, but if you remember, I said that low frequencies do not work for tremor. And I wonder if that's partly because low frequencies are amplifying the circuitry that we think may be responsible for generating, or at least be contributing for generating tremor. So I don't know, I mean, obviously, but this is just the first step, or a first look into how we can use neurostimulation to modulate these circuits. But of course, being in humans, we really are making a lot of inferences when we make these statements. So the treatment of neuropsychiatric diseases in general, we said, follows this one size, that should be size, fits all model. And in the case of neurostimulation, the stimulation or the brain pacemaker is on all the time at the same parameters that are used for several different symptoms and diseases. And hopefully in a few years, not too many years, we will look back on this era and say, wow, I'm amazed it worked. So can we use kinematic or brain signals responsible for the specific motor or other behavior to develop more precise, customized, and responsive therapies for a broad range of neuropsychiatric diseases? So right now we have open loop, one size fits all. We're using the same parameters for all diseases, and it's really not a very smart pacemaker or stimulator. We're beginning to understand some of the neural signals that contribute to some of the abnormal movements. We've got a lot more work to do there before we can really understand the correct signals to use. So now we come back to this diagram, and now we've got access to this circuitry. We've developed some quantitative kinematic measures. So what can we do to use these to drive neurostimulation? So let me just back up for a second because I want to introduce this slide. So one of the first things to think about is tremor. And in a paper in 2009, when I told you I looked at 5 resting states and asked whether the resting state was conserved, and then there were periods of DBS in between, periods of movement that attenuated it, and it kept coming back to the same state except for one person. And Krista Barberini, my postdoc at the time, went back and laboriously went through every single video of every single resting state to make sure that there was nothing else going on. And in this one person, she saw that in the first 2 resting states, which were these 2, there was resting tremor the whole time. And then we applied DBS, and the resting tremor went away and never came back. And after that, the other 3 resting states, you saw this beautiful beta band appear. And we've published that in that paper. And we showed, there seems to be some functional attenuation of beta during tremor. And so you can see, here's a nice video. We're recording the signals from the patient's hand, and we're recording local field potentials. And in patients for whom there was a spontaneous resolution of tremor while we were recording in the OR, we didn't do anything, you can see that the beta band emerged as the tremor went away. So anybody thinking about closed loop using resting state beta is going to go, that might not work. Because as soon as basically if you flip that around, if beta goes away, stimulator's going to go off, and it's not going to do anything for the tremor. The first step to move towards closed loop neurostimulation, everything has to go through the FDA, everything has to be very safe. The first step that Medtronic took was to develop something called Nexus D, which is basically a bidirectional conduit between the INS, the implanted neurostimulator, which is also the brain, and a portable PC on which we can put the sensing algorithms and control policy algorithms. But when they did this, first of all, they compressed the data, because data download using this first generation of devices is extremely long. You basically had 15 minutes of recording and another 15 of downloading. So they compressed the data to try and make that shorter. And what happened was, as soon as we had stimulation on, there was this massive artifact right through the beta band, so we couldn't do any neurally triggered stimulation. So we said, hey, why not? At this point, we'll do some kinematic triggered stimulation. So in Howard Chiswick's lab, Jeff Heron and Howard Chiswick had been for a couple of years working with Medtronic, basically with oscilloscopes to develop a smartwatch that was Bluetooth enabled and communicated with this PC. So we did a collaboration with them, and we used this smartwatch and had the patient just sitting with the other side on so that tremor wouldn't interfere from the other side, and just had it resting on their leg so that we could measure tremor from the leg and the hand. And this here is the wearable sensor, and you can see the angular velocity of tremor was picked up by the PC. We did an FFT of the tremor power, did a calibration, and then asked the stimulator to sense tremor. And again, is this going to work? This is the first time anybody's done this. Is it working? It worked in the sheep. Is it going to work in the human? So we published the feasibility study a little while ago. And this is one person, again, a nice continual recording. And what this is here is, this is extracted and estimated tremor power from a calibration period. And this is the voltage of stimulation. And what we're doing here is we based on the calibration of the tremor initially, we choose thresholds. And if the tremor rises above that threshold, then we're going to ask the stimulator to increase its voltage. And if it goes in between these thresholds, it'll do nothing. And if it goes below this threshold, the stimulator will start decreasing. We had to do an awful lot of preparatory work determining what's the safest ramp-up speed of the voltage for the patient and the ramp-down speed, and found, in fact, that if we ramped down too quickly, we almost had a recurrence, we sort of had a rebound of tremor. So we ramped up at the fastest speed that the patient could tolerate so that we could grab that tremor and get rid of it. And then we ramped down at half the speed. So this is an insert from here, and you can see again tremor going up over this upper threshold, stimulator kicks in, it stays stable, then it goes down. And so you can see the way that it worked, and it worked. And this is a person who had fairly continuous tremor, so that as it came down again, it kicked in. So it was basically, the tremor was responding when we had the voltage applied, but otherwise when we slowed it down, the tremor would come right back. Across the group, there was definitely an improvement in tremor compared to the calibration period, and compared to if you'd had the stimulator on for 30 minutes, there was a dramatic difference in the amount of power we used. What I thought was the most interesting thing was, even among 5 subjects, 10 STNs, how different these people were in their natural behavior. And this is another subject, same exact experiment. And you can see here, tremor goes up, stimulation goes on, stimulation gets rid of the tremor, and then there's nothing. Burst of tremor, nothing. So for the people who take care of these patients, we know that there's tremor and then there's tremor. People's tremor is very different. And so for this person, in actual fact, this person basically used the stimulator about 11% of the time. So one of the most interesting things across the group, which these numbers are probably too small for you to see, but this is the percentage of time or the percentage of power compared to if the stimulator had been on for the 30 minutes that were used. And you went from basically 11% to 99%. So the take-home message here is we shouldn't be doing a one-size-fits-all therapy for everybody. This person, depending on how much bradykinesia and rigidity they have, they may need some low-lying, adaptive DBS based on their neural rhythms, and then a kick-in every time, with something else, maybe a different frequency. And then there may be somebody who basically, even with tremor, needs this on all the time. So I have a couple of slides about neural and kinematic triggers that we're now using, but I took them out because it's too much. But I'm happy to show them to people. It's not yet published. But that is the next experiment that we are now doing with what's called Nexus D3. And in fact, what we have now is a fully embedded system. So we have 21 subjects who were implanted. We deliberately chose different phenotypes because of our initial brain radio proposal, and tremor dominant and akinetic rigid, of whom there are several freezers. Kinematic adaptive DBS has been successfully performed in 18 STNs from 10 subjects now, using the external, that's PD, sorry, that's PC. I write PD all the time. My brain must have just thrown that in. With reduction in tremor in the overall group by about 37%, using 76% lower voltage than continuous DBS, and for an average of 52% of the time that the continuous DBS would have been on. 18 subjects have consented to and were successfully upgraded with the embedded adaptive DBS algorithms. So this is something, again, has to go through the FDA each time, required a firmware upgrade. And we've actually tested the safety and tolerability of adaptive DBS using a neural trigger in 19 STNs now. And in actual fact, we did our first fully embedded adaptive DBS experiment a couple of weeks ago with the gentleman you actually saw in that video. And the feedback we got from him was really quite dramatic. I mean, even though he's using, for his clinical DBS, he's using 3 electrodes on that lead in a monopolar setting. So that's a big field at 3.7 or 3.8 volts. We can only use 1 lead because we're recording around it. And still, he gave us feedback that he felt like he was on the 10-mile bike ride that he told me was the biggest problem he had coming into that clinical visit, that he felt like he was just losing power. He said it was like being on that bike ride, and all of a sudden, the gears downshifted and he took off almost before he realized he was getting tired, and it happened to him several times. So it was really something that, with all the scientific work we've done, being skeptical about whether beta has anything to do with PD behavior, that was the one statement that suggested to me that it really does have some functional relevance. And so obviously that's one person, and you can imagine the next subjects we study won't feel anything. But it was pretty exciting. And I'll stop there.
All right, looks like you knocked him out, I think.
Sorry about that.
Is the main goal of the closed-loop DBS to reduce the power?
That's a really good question, and we were talking about this today. So the closed loop, so the first paper looking at, some people call it closed loop adaptive DBS, was published by Simon Little and Peter Brown in 2013. And they had a few subjects, and they had they don't have to go through the FDA, so they had a sort of custom-made device, and they used the resting state beta power, and they kind of deliberately used the algorithm so it would only be on 50% of the time. And then they compared that to how the patients did with continuous DBS, and then with just a randomized presentation of DBS so that it was on 50% of the time, but it wasn't following the rhythm. And interestingly, and they only used those UPDRS, they used a few of the bradykinesia tasks in our scale to measure outcome. And they showed that the adaptive DBS was better than continuous DBS and better than random DBS. And they had designed it so that it was only on 50% of the time. I think that set up an unrealistic expectation for the field, because for most subjects, they do very well with continuous DBS, otherwise the procedure wouldn't be around. And so if you're really, I don't think the bar that you want to compare closed loop with. But I think what I was trying to frame out in this talk is the underlying neurophysiology is, why do you want to stimulate the brain, or do you have to stimulate the brain continuously at this high frequency 24/7? And is in fact that leading to some alterations in the brain that are maladaptive? And what was fascinating to me with this N of 1 is that using one electrode, somewhat less power, we're doing the analysis right now, the patient felt better. And do we actually want to have something that's working with and adapting to brain rhythms or kinematics? And may actually that be more efficacious for the patient? So we don't get to spend 24 hours with our patients. And we all know that in the end of the day, they begin to really get exhausted. And medication-wise, there's not a lot we can do for them. We give them a little bit of extra Cinemat. And it's one of those things in Parkinson's that's always kind of frustrated me, is why is that happening? Well, this guy said that at least with that period of ADVS, what he felt was that when he naturally was just losing steam, he got this kind of kick. So I don't know if it's a differential that's going to be what may make this more interesting to the patient. There are side effects from continuous high-frequency DBS, one of which we believe is speech. So if you turn down frequency, people feel that their speech is better, but it doesn't control their tremor. So immediately there's a thought, can you use different frequencies to improve axial and bradykinesia symptoms, and maybe only have to use high frequencies in a sort of stochastic manner?
Are you measuring some of these things like memory and speech and some of these other things?
Yeah, we are now. We're now designing sort of, that was our first check, does it work kind of experiment, and now we're designing the adaptive DBS experiment that obviously we will blind the patient as to whether they're on continuous or adaptive. The thing that's really interesting me that I didn't talk about too much right now, it's not yet published, is this whole idea of which band you would use. And I think that might be also very interesting, and there are certain groups beginning to look at that.
So I think one of the things that's always been the most confusing to me about DBS is that you turn it on and you get this immediate electrophysiological change, and you also then get a very slow, time-delayed clinical response and different symptoms, right? And then you turn it off, and at least the data that you showed, you get this immediate return of the electrophysiological signature, but you know, the symptoms don't necessarily come back immediately too. And so there is this disconnect there. And you know, well, one, I can't understand how in the world you could stimulate someone 24 hours a day for a year and then just turn the device off and immediately like things go back to normal. Like that blows my mind. Like how is that possible?
Obviously it doesn't come back to where it was before.
Yeah.
And that's probably not going to be true for everybody, but it was true when we did the statistics across the group. And nobody really understands this. The interesting thing about the axial phenomena is, the word on the street is that DBS does not improve freezing of gait. We were handed some incredible freezing of gait patients, also from my other colleague, Dr. Poston, and at least one of Kathleen's patients was just basically didn't freeze afterwards. They've all improved on their freezing of gait. And I think what you're going to see is maybe beta's not going to be everything. It's going to be more specific to different motor features. But I think maybe some other aspects, not just beta power, but some of the other aspects are going to be very interesting for some of these other abnormalities of motor control. So that's what I think we need to start thinking about.
When you did run the adaptive DBS, you know, live in the patient, and the device was turning itself on and off, did the patient know? Did they have like a paresthesia effect when it was turning on and off?
So we do a lot of work to determine what we call Vmax, and then what my engineer calls Vtrem, and then confuses everybody when we're looking at bradykinesia, but it's just easier for her to think of it as one label. And that is, she does some very nice work where she does titration of voltages, and she's measuring the movement, and we find a voltage at which the patient is okay, but may not be at its best, and we use that as the threshold to work around. And what you see with neurally driven ADBS, we don't turn it off, is that it actually tends to move itself around a threshold. It doesn't tend to go up and down, except in these tremor patients who have low beta signal. Then we actually get this signal going up and down. And so we're looking at that very carefully in people who have tremor and moderate good beta signals and people who have low beta signals. Because I think for a commercial entity like Medtronic or any of the other companies, you're going to need to make sure that your device is not just going to track beta, because you may have some subjects who don't do well with it. The idea of why things come back right away and why others don't, again, I think it's a generalization to say that for everybody. There are patients whose tremor just comes back right away. In fact, there's a patient in our group who cannot do any more off-stimulation testing, because when we turn off stimulation, his tremor is so violent that he can't stand it. So we only do on DBS experiments with him. And there are other people you saw, you turn off DBS, and what the guy, actually, the person we were testing, who's patient number 1, who was tremor dominant, we were trying to do this experiment, and we ended up only doing the neural because we turned him off for the whole day, and his tremor didn't come back. Got me. For those of you in basic science, this is the downside of clinical research. It's not very, it drives my engineer absolutely nuts. She likes a damped oscillator that behaves, but it's just all very, very different.
I'm wondering if the link between the stimulation and the beta power helps to figure out what is the mechanism of DBS. In particular, how does the stimulation could locally affect beta power and still be related to symptomatic effects?
Yeah, so that's such an important question. And that was why we did the 60 hertz and 130 hertz experiment. Because so far, all the studies have been associative. So when you use high-frequency stimulation, that beta band attenuates and the patient gets better. And when you give them medication, the beta band attenuates and the patient gets better, which led everybody a good 5-8 years ago to say, beta band is a biomarker of Parkinson's disease. But in actual fact, those were associative. And so that's why when we found that you had a frequency of stimulation that actually amplified that rhythm, our question was, well, can we now ask a causative question? Because if you amplify the rhythm and the behavior still gets better, then can we really say that attenuating beta is the therapeutic mechanism of DBS? In actual fact, what happened was we amplified a low-frequency band, and we attenuated the high-frequency band. So you could still say, well, now we know that the therapeutic mechanism is to attenuate high beta oscillations. And that low beta has really got nothing to do with it. Actually, the field up to now has suggested that it's the low beta oscillations that are akinetic. And Peter Brown has published a paper suggesting that high beta is physiological. So we clearly don't know. And that's why I think this next step, which is doing some structural and physiological work to try and understand whether there are different circuits that are using different frequencies really for what they do, if we can say that, that's really interesting, because then all of a sudden we're saying, well, maybe the mechanism is to wipe out that cortical reflection of beta that's coming through the hyperdirect pathway, but actually what's coming through the striatum is not important. That's sort of almost the opposite of what most of us think. We think those striatal circuits are really important. And maybe that's only important for bradykinesia, and it's not important for tremor. So I think, we're really just kind of the tip of the iceberg of trying to understand this. So I think the truthful answer would be we still don't really know the mechanism of DBS. Would you agree?
Oh.
He's the biggest skeptic. Huh?
I wonder if I could ask something related to Andy's question. If the DBS in closed-loop control is on 50% of the time, as the disease progresses, do you expect that it will remain 50% or will it increase?
Well, that's a really good question. So the fact that we see chronic DBS, attenuating that band would suggest that if you had an adaptive system, it would start to lower the voltage it's using. We don't do that in clinical practice normally, but maybe that's because there's tolerance developing when you just have it on all the time. Maybe they really don't need that kind of voltage, and that over time, if you're following this band, they'll be just fine with a lower voltage or, you know, like he did, one electrode. Or maybe this thing's just not going to be efficacious as it drives down beta band. We really don't know any of the answer to that. What we do know is what I saw, which is, again, correlative, but the side that was being treated and doing very well, beta's going down. The side that's not being treated, that band is actually growing. So it's dynamic. It's doing something over time. So it's growing with that stage of disease. So it's very enticing to hope that maybe if we keep attenuating that band, it will translate into improvement. And you know, we know that this is an incredibly stable therapy. I mean, we're coming up now to 17 years of implantations at Stanford. And I still treat my second patient through, who was on the Olympic running team. And she is now in her mid-60s, and she still only takes a tablet of Cinnamate when she goes running. And she's been on this for almost 17 years. And she's lucky. She was young onset. She actually hasn't got cognitive or axial involvement. She has speech problems. And so she does a lot of speaking in the community and talks about what it's like to have Parkinson's disease and look a little akinetic, but she doesn't want to take meds, but basically not have too many motor problems, but she still has the disease. But that's, you know, again, these anecdotes of people who have done very well with this therapy. We're clearly keeping those symptoms, at least in the motor circuits, at bay for those people.
All right. I think that's good. Thanks a lot, Helen.
You're welcome. Thank you.